Assalamu alaikum. I hope you all guys are fine and doing great. So, coming forward with the second lecture of our virtual general conference on oral health awareness. So, I will be introducing my mentor, another mentor, and another great teacher, and he's the international guest speaker from Canada. His name is Dr. Naghman Zuberi. So, without any delay, I would like to welcome Sir Dr. Naghman Zuberi. Assalamu alaikum, sir. How are you?
Walaikum Assalam. I am good, thank you. What about you?
Sir, Alhamdulillah, I am also fine. So, sir, over to you. You can take it from here.
Um, Welcome everyone. Bismillahir Rahmanir Rahim. So today we will be discussing about new classification of the periodontal and peri-implant diseases and the conditions. If we talk about the periodontal health, what does it mean? Periodontal health is defined as an absence of clinically detectable inflammation. There is a biological level of immune surveillance that is consistent with clinical gingival health and homeostasis. Clinical gingival health can be found in a periodontium that is intact, means it does not have any loss of clinical attachment or any bone loss, and can be found even after some reduced periodontium is there, like after some disease which is treated, or the loss of periodontium is because of any other reason, like maybe crown lengthening procedures, etc., which we call non-periodontitis clinical attachment loss or non-periodontitis reduced periodontium. Well, clinical gingival health can be restored following the treatment of gingivitis as well as periodontitis. But remember that the treated and stable periodontitis patient with current gingival health, they remain at the increased risk of recurrence of the disease, and they should be kept under surveillance for almost rest of the life. What is gingival disease? Two broad categories of gingival diseases include non-dental plaque biofilm induced gingival diseases and dental plaque induced gingivitis are there. So let's see non-dental plaque biofilm induced gingival diseases. They include a variety of conditions that are not caused by plaque, and usually they do not resolve following the scaling and root planing, which we call plaque removal. These lesions may be manifestations of a systemic condition, or they may be even localized only to the oral cavity due to any reason, any other reason. Well, the common gingivitis, which we call the dental plaque induced gingivitis, it has a variety of clinical signs and symptoms, and both local predisposing factors and systemic modifying factors, they also affect the extent, severity, and the progression of this disease. Dental plaque induced gingivitis may arise on an intact periodontium or on a reduced periodontium in either a non periodontitis patient or in a currently stable periodontitis patient. Means where we have successfully treated periodontal condition or periodontal disease, we have eliminated the inflammation. So that inflammation is no more there. Patient is having a stable condition, but periodontium is reduced. A periodontitis patient with gingival inflammation remains a periodontitis patient, and comprehensive risk assessment and management are imperative to ensure early prevention as well as treatment of the recurrent or progressive periodontitis. So if we look at this chart, it tells us that patient with the periodontal health can go into the gingival inflammation, and if it is properly treated, the health can be restored. But here we do not have any periodontal condition, only gingivitis is there. But this gingivitis can progress into periodontitis. From here, if the disease progresses to periodontitis, it cannot come back to this situation. Means, which we call periodontal health on intact periodontium. Here we will be, if we treat the patient, we will be having three possible outcomes. One will be periodontitis patient, which will be having stable periodontal health, but we have reduced periodontium. Another periodontitis patient may have some gingival inflammation, and periodontitis patient who is unstable and is going to have recurrent periodontitis. If we look at the biology of the clinical gingival health is generally associated with an inflammatory infiltrate and a host response consistent with homeostasis. On a site level, how do we classify the clinical gingival health? Site means the probing site. We know that there are three facial and three lingual probing sites where we find the probing depth, where we find the bleeding upon probing of one tooth. So there are six probing sites. So, on a site level, how do we classify the clinical gingival health? Clinical gingival health on an intact periodontium, as I told you, where we do not have any loss of the clinical attachment. Clinical gingival health on a reduced periodontium, it could be a treated case of periodontitis which is stable now, so it is reduced periodontium, but it is a stable periodontitis case. Or it could be reduced periodontium without any like periodontal condition, like the periodontal inflammation. It is because of some non-periodontitis reason, like maybe a recession or crown lengthening procedure have been performed. Gingival health comparison, if we talk about it. Gingival health on the intact periodontium, clinical gingival health on an intact periodontium is characterized by the absence of bleeding on probing, erythema and edema patient symptoms, and attachment and bone loss. Physiologic bone level, they range from 1 to 3 millimeter apical to the cemento enamel junction. Gingival health on reduced periodontium, clinical gingival health on a reduced periodontium is characterized by an absence of bleeding on probing, erythema, edema, and patient symptoms in the presence of reduced clinical attachment and bone levels. It should be successfully treated, and stable periodontitis patients remain, as we have already discussed, at an increased risk of recurrent progression of periodontitis. In the non-periodontitis patients with reduced periodontium, I have already mentioned that these are those patients where either because of the recession could be because of age-related factor, or it is because of some procedure which we have performed, like the crown lengthening procedure. So it would have caused the this reduced periodontium, but now patient does not have any sign of inflammation, so we will consider it as gingival health on the reduced periodontium in a non-periodontitis patient, we will call that. Clinical features following treatment. On an intact periodontium, the clinical gingival health following treatment of gingivitis on an intact periodontium is characterized by the absence of bleeding on probing, erythema and edema, patient symptoms, and there is no attachment and bone loss. On reduced periodontium, same thing, clinical gingival health following successful treatment of periodontitis is characterized by an absence of bleeding on probing, erythema, edema, and patient symptoms in the presence of reduced clinical attachment and bone levels. Periodontal health and gingivitis. Based on the available methods to assess gingival inflammation, a gingivitis case can be simply, objectively, and accurately defined and graded using a bleeding on probing score, which we also call percentage of the BOP, bleeding on probing in percentage. It is assessed as the proportion of bleeding sites, that is, just yes bleeding or no bleeding. No other explanation about it, yes or no. So, dichotomous yes no evaluation. When stimulated by a standardized the dimensions and shape, periodontal probe with a controlled up to the force applied is 0.25 Newton to the apical end of the sulcus at those six sites which I told you. And what are those six sites? The mesiobuccal site, buccal site, distobuccal site, and the mesiolingual site, lingual site, and the distolingual site. We are talking about only one tooth. So every single tooth will be assessed at these six sites. In clinical practice, a case of gingival health on an intact periodontium would be a patient with no signs of gingivitis may exhibit one or two sites with some evidence of clinical gingival inflammation. So, clinical practice means being very practical. We will say a case of gingival health may have very few, maybe one or two sites where we will find some bleeding upon probing. We will still consider it as a non-gingivitis patient, or we will call it periodontal health. We will not consider it as gingivitis. Same is true for a patient after periodontal treatment on the reduced periodontium, like either intact or the reduced, they are not having more than few sites where there would be some sign of bleeding upon probing. We will still consider it as periodontal health. Periodontal stability. Following treatment of periodontitis patients may not attain a status of complete gingival health based on the above definition. However, evidence has demonstrated that a patient may achieve periodontal stability. Periodontal stability is characterized by successful treatment through control of local and systemic risk factors. So there will be very minimal bleeding upon probing percentage. And what is that? Less than 10% sites they will be having bleeding upon probing. No probing depth means the probing depth is not more than 4 millimeter anywhere. All the sites they have probing depths less up to or less than 4 millimeter. Optimal improvement in other clinical parameters and lack of progressive periodontal destruction. Gingivitis. There are broadly two categories of gingival disease: the dental plaque biofilm induced gingivitis, which I have already mentioned, and non-dental plaque induced gingival diseases, which could be because of some underlying conditions or maybe some local problem which is present in the oral cavity. Dental plaque biofilm induced gingivitis, the commonest form of gingivitis. Dental plaque biofilm induced gingivitis is defined at the site level as an inflammatory lesion resulting from interactions between the dental plaque biofilm and the host, the patient's immune inflammatory response, which remains contained within the gingiva and does not extend to the periodontal attachment, means we will consider it gingivitis only if periodontium is not affected, only gingivae are inflamed. Means cementum, periodontal ligament, and alveolar bone are not affected. Such inflammation remains confined to the gingiva, as I have already mentioned, and does not extend beyond the mucogingival junction and is reversible by reducing levels of dental plaque at and apical to the gingival margin. Well, depending on whether dental plaque biofilm induced gingival inflammation occurs on an intact or maybe a reduced periodontium or in a patient diagnosed with periodontitis, gingivitis can be further classified as we have already discussed gingivitis on an intact periodontium, gingivitis on a reduced periodontium in a non-periodontitis patient means having recession or crown lengthening procedure, or gingival inflammation on a reduced periodontium in a successfully treated periodontitis patient. Now we have two conditions we have discussed. The gingival health. Gingival health could be in intact periodontitis or it could be gingival health in reduced periodontium. Well, similarly, gingivitis could be in intact periodontium or it could be gingivitis in reduced periodontium. Same thing. So, if there is inflammation, we will call it gingivitis, but we have to mention whether it is intact periodontium or we have to mention whether that in the other case the reduced periodontium. What is the reason? We know it, whether it was a periodontitis case or it was non-periodontitis reduced periodontium case. Local risk factors, which we call the predisposing factors. Local risk factors for gingivitis are those that encourage plaque accumulation at a specific site by either inhibiting its removal during daily oral hygiene practices and or creating a biological niche that encourages increased plaque accumulation. And what are those? Plaque or oral biofilm and xerostomia or dryness of mouth. These are the two local risk factors. Systemic risk factors, they include smoking. Smoking is the commonest and most important risk factor, modifiable risk factor. Then comes metabolic factors like diabetes mellitus, nutritional factors like vitamin C deficiency, pharmacological agents, maybe certain drugs which may cause gingival hyperplasia, elevations in sex steroid hormones, and which, when it occurs, puberty, pregnancy, oral contraceptives. Which one? The first generation oral contraceptives. Then hematological conditions like leukemia. These are all systemic risk factors, which we also call modifying factors, out of which, remember, smoking is the most important and commonest modifying risk factor. Signs and symptoms of gingivitis. Swelling, we are talking about signs. Swelling, seen as loss of the knife edge gingival margin, and there will be blunting of the papillae. Papillae will appear as rounded now. Bleeding on gentle probing, redness and discomfort on gentle probing. Symptoms will be bleeding comes, patient will be complaining of metallic or taste or maybe altered taste, pain, halitosis, difficulty in eating, appearance of the gum. They will be appearing swollen red, reduced oral health related quality of life. Well, when there will be gingivitis, we are not going to have any radiographic signs. When it is intact periodontium. But if it is reduced periodontium, so already that reduced periodontium, it will be appearing on the radiograph that there is reduced periodontium. If we have some old x-ray, we can compare with it, and there must not be any further loss of clinical attachment loss occurred, or maybe no further loss of the bone. So supporting structures will be at the same level as they were when treatment was done, and we declared that the patient is now stable after the treatment. Diagnostic lookup table for gingival health or dental plaque induced gingivitis in clinical practice. So, what it would be like the three conditions I told you: intact periodontium, the probing attachment loss will not be present, gingivitis will not be present. Probing depth, assuming no pseudo pocketing, means patient is not using any drugs or they do not have any familial gingival enlargement. So it will be almost up to or less than 3 millimeter. Even if gingivitis is there, it will be up to or less than 3 millimeter. Bleeding upon probing in health, the sites will be less than 10%. In gingivitis, could be up to or more than 10% sites, which will be having bleeding upon probing. Radiographically, health, no, and gingivitis, no, because it is intact periodontium. In reduced periodontium, in the non-periodontitis patient, means they never had periodontitis. The reduced periodontium is because of some other reason. The probing attachment loss will be present because it is reduced periodontium. Yes, it will be. In gingivitis, it will be present. But it is not because of the present condition. It is already patient had reduced periodontium because of some other reason. So probing pocket depth, it will be less than or up to 3 millimeter in health, and in gingivitis, again, less than or up to 3 millimeter. Bleeding upon probing, up to less than 10%, and bleeding upon probing either up to 10% or more than that in case of gingivitis. Radiographic bone loss, as I told you, possibly it will be there in both the cases because it is reduced periodontium, non-periodontitis patient. Successfully treated stable periodontitis patient, already patient was periodontitis patient, we have treated and we declared that they were stable by our previous treatment. Now, in case of health, what would be the situation, or in case of gingival inflammation, what would be the condition? Probing attachment loss, it will be present because patient was already a periodontitis patient whom we treated, and whatever the damage has occurred, it will stay there. Similarly, even in gingivitis, there will be probing attachment loss we will find. Probing pocket depth, all sides, and assuming no pseudo pocketing, they will be less than or up to 4 millimeter, but no site should be more than 4 millimeter with bleeding upon probing. And in gingivitis, it should be less than or up to 3 millimeter. In health, we can go up to 4 millimeter in successfully treated case. We can still consider it. But in gingivitis, we are confining ourselves up to less than 3 millimeter or up to 3 millimeter. Bleeding on a probing less than 10% sites. Here they will be more than 10% sites. Radiographic bone loss in both the conditions will be present. Severity of gingivitis. Methods of defining gingivitis may include defining the percentage, for example, in mild cases, less than 10% sites, moderate 10% to 30% sites, severe more than 30% sites. Grading is on grade 1 to 5 in 20 quintiles, means 5 equal groups, 20%, 25%, uh, then it will be like we will be adding up to 100%. 1 to 5 we will be making it like 20%, 40%, 60%, 80%, and 100%. So grading will be like that, 1 to 5. 1 means only 20%, then 2 will be 40%, 3 will be 60%, 4 will grade 4 will be 80%, and grade 5 will be 100%. When we talk about the non-dental plaque-induced gingival conditions, there are so many conditions which may contribute towards the gingival inflammation. They could be genetic or some specific bacterial or viral or fungal infections. I'm not going into the details because we do not have that much time, but maybe someday we will be having a lecture completely on these things. Just to introduce you about the new classification, that's why the basic idea of this lecture was that we are introducing you to the new grading system and new classification system as proposed by the American Academy of Periodontology. Then reactive processes like apelase, fibrous apelase, calcifying plasms, which could be pre-malignant conditions or malignant conditions, then endocrinal reasons, vitamin deficiencies, traumatic lesions. Stages of periodontitis. Periodontitis is categorized into different stages. Stage 1 periodontitis gaps less than or up to 4 millimeter, but there will be clinical attachment loss of less than or and will require non-surgical treatment only, means scaling and root planing will be adequate. No post-treatment tooth loss is expected, indicating the case has a good prognosis going into the maintenance. Stage 2 periodontitis, moderate disease. Patients will be having depths less than or up to 5 millimeter with a clinical attachment loss of less than or up to 3 to 4 millimeter. Still, the bone loss will be horizontal bone loss and will require again non-surgical as well as surgical treatment. No post treatment tooth loss is expected, indicating the case has a good prognosis and when it will be going into the maintenance. Stage 3 periodontitis, the severe disease, patients will be having probing depths more than or up to 6 millimeter with a clinical attachment loss of more than or up to 5 millimeter and may have vertical bone loss. Now here, vertical maybe vertical bone loss and or furcation involvement as well, which could be class 2 furcation involvement or class 3 furcation involvement. This will require surgical and possibly regenerative treatment, guided bone regeneration. There is the potential for tooth loss from 0 to 4 teeth. Could be no loss, but can maybe up to 4 teeth loss. The complexity of implant and or restorative treatment is increased, the patient may require multi-specialty treatment. The overall case has a fair prognosis going into maintenance. Then comes the last stage, very severe disease, stage 4 periodontitis. This patient will be having probing depths more than or up to 6 millimeter with a clinical attachment loss of more than or up to 5 millimeter and may have vertical bone loss and or a furcation movement involvement of class 2 or class 3. There is potential for loss of another 5 or more teeth. Advanced surgical treatment and or regenerative therapy may be required, including augmentation treatment to facilitate and or restore functional integrity. Require multi-specialty treatment. The overall case has a questionable prognosis when they will be going into the maintenance phase. Stages of periodontitis. Staging is designed to give information about the whole mouth relative to the severity and the complexity of the disease. The stage difficulty and complexity of the required treatment as well as expected prognosis, since it provides some perspective on the individual patient's response to the disease challenge at the time of the examination. A patient in their 30s or 40s with past destruction and case complexity consistent with stage 3 or 4 should be considered very differently because age matters. Younger the patient, poorer the prognosis of periodontal disease. Elderly the patient or uh, aged the patient, we will be giving them better, like the prognosis, and we consider it a case where prognosis is going to be much better. The reason is, younger the patient, we know that certain bacteria like the aggregative bacter, actinomycin comitans would be involved, and it would be the aggressive periodontitis. We are not using the term now the aggressive periodontitis. We call it the periodontitis at younger age with molar, first molar, and incisor involvement. The staging system, like, so sorry, I was talking about this. So with stage 3 or 4 should be considered very differently with a patient with stage 1 or 2 disease and complexity. The staging system is designed to highlight the patient's most severe areas of destruction, which usually require more complex case management. When a patient has periodontitis with a combination of generalized mild clinical attachment loss of 1 to 2 millimeter and probing depth of less than or up to 4 millimeter to moderate destruction of clinical attachment loss of 3 to 4 millimeter with a probing depth of less than or up to 5 millimeter and localized severe destruction of clinical attachment loss more than 5 millimeter or up to that, or with the probing depth more than or up to 6 millimeter, he should or she should be given a diagnosis of generalized periodontitis stage 3 or possibly 4 if more than 5 teeth are missing due to periodontitis. Now, in the staging table, tooth loss is defined as tooth loss due to periodontitis, not those which you extracted because they were having some pericoronitis or because of some endodontic involvement, or maybe endodontic failure, or maybe gross caries, or because of orthodontic reasons. Those are not going to be considered. Only those teeth which were lost because of periodontal involvement. Tooth loss should include those teeth planned for extraction due to periodontitis as part of active therapy. Like, say, for instance, patient comes to us and patient does not have any tooth loss, but we identify that maybe within next few weeks, or maybe within next few days, we are going to extract three teeth or four teeth because they are severely involved periodontally. So those will be considered as tooth loss, and it will be affecting our staging in this periodontal classification. If a patient is diagnosed with periodontitis, had previously lost two teeth due to periodontal disease, and they have an additional three teeth that clearly require extraction due to periodontal destruction, those teeth planned for extraction should be included in the count of teeth, as I told you, lost due to periodontitis. Thus, the patient would have five teeth lost due to periodontitis, and they are going to be classified in the stage 4. The stage typically does not regress, it only proceeds forward in case of some progression of the periodontal disease. If the patient has been treated and is now clinically stable, then these patients, they are described as having periodontal stability only. If during maintenance sites demonstrate further clinical attachment loss, radiographic bone loss, and deeper probing depths, it becomes an unstable case of recurrent periodontitis. In this case, the stage could change to a higher level depending on the criteria, means we will see loss of more teeth due to periodontal disease, development of furcation involvement, it could be class 2 or class 3, or maybe development of vertical bone defect. There is an exception to this rule, only one exception. And that is if the case was classified as stage 3 due to the presence of a vertical defect of more than 3 or up to 3 millimeter, or class 2 furcation involvement, and those were successfully treated with some regenerative procedure like the guided bone regeneration, such that the clinical attachment loss throughout the dentition is now up to 3 to 4 millimeter. The furcation involvement is class 1 or not clinically detectable, and probing depths are less than 5 millimeter or up to 5 millimeter. The stage could change from stage 3 to stage 2. That is the only where we have treated either a vertical bony defect or this furcation involvement using the regenerative procedure. That is the only thing. Once the stage is determined, when the percentage of teeth affected by periodontitis is assessed, this provides information about how many teeth are affected by periodontitis, which is expressed as localized or generalized. It does not give information about the percentage of teeth with slight, moderate, or severe destruction. Distribution refers to affected teeth such as first molars and or incisors, which is totally different type of clinical presentation. As I have told you, the which we used to call previously the aggressive periodontitis. Only first molars and incisors are involved, and usually it occurs in young individuals. So it has totally different type of clinical presentation that should be noted and may have some treatment implications. Use of grading system. Grading provides the likelihood of post-treatment disease progression. It is loosely based on previous clinical studies from private practices that classified the post-treatment as well-maintained, downhill, or extreme downhill. This is based on the amount of post-treatment loss. The diagnostic recommendations are A, B, or C, signifying slow or no progression, moderate like B, moderate progression, and C, rapid progression, respectively. The assessment include diabetes and or smoking and the systemic impact of the periodontitis. Only one grade is assigned to the patient. It is based on either direct or indirect evidence of the rate of disease progression and risk for future progression. Other risk factors or grade modifiers such as smoking or diabetes mellitus may also be considered for their contribution to the rate of disease progression in the present or in the future. A patient with a grade B rate of progression does not have to automatically become C if their HbA1c means the hemoglobin, the glycated hemoglobin level is 7.2%. In the judgment of clinician, the progression of the disease is not significantly impacted by this level of diabetes control. Well, however, if the hemoglobin level is 9% of the impact on future attachment diabetes control, however, the HbA1c is 9%, impact on future attachment loss and response to the therapy may be greater, which would prompt the clinician to assign a grade of C. The same reasoning may be applied to a patient who smokes more than 10 cigarettes per day. The question to be asked is what impact has the patient's smoking habit had on the current amount of attachment loss and on future loss of attachment or response to therapy? If current smoker is assigned a grade C, smoking cessation would be incorporated into the treatment plan. If patient has diabetes mellitus, which is in moderate or poor control, means the HbA1c is 7% and a grade C is assigned, the patient will be informed that their level of diabetes control most likely has contributed to periodontitis. In addition, if control is not improved, there is a risk for future progression of periodontal disease. This patient would be preferred to their physician, like they should be referred to their physician with better control if possible. The treatment timing should directly be influenced by patient compliance. More intense maintenance therapy may be recommended as part of the treatment plan for both types of the patients. Well, this staging may attribute to the complexity of the long-term management, case management. Initial stage.
I think the sir connection has been disconnected. Just wait for 2 seconds so that sir can rejoin back. Let me check. Sorry, guys, for the inconvenience. I think the connection of sir has been cut due to internet connection, low internet connection here. So, as you guys all know, that we have like other 2, 3 or more sessions as well. So, I would request you guys to continue looking at sessions as well. The next session is on the plaque management, and soon I will be starting there as well. So, I would see like wait for 1 or 2 minutes. If sir can rejoin, then we can continue. Otherwise, we will see you guys in the next session. It will be hosted by Dr. Moiz Ahmed. ठीक है? So without, let's see like if sir can join back in 2 minutes. Mhm. So I think the time is over as well. So I will over this presentation. Inshallah, sir will continue the presentation next time because we have time shortage. So thank you guys for listening this session and sorry for the inconvenience. I think the like net at the end there was a net problem. That's why sir get disconnected. But inshallah we will be continuing this last 2, 3 slides in the future as well. So thank you. Khuda Hafiz. Kya rakhiyega.